atherosclerosis or propagates atherosclerosis. That's just the finding, and there's no data contrary to that at all. There's no published literature that says it doesn't cause more atherosclerosis. So I'll replete men with testosterone if they really want it, but I make sure they have a CT angio that shows they don't have a lot of plaque, and I follow serial CT angios to make sure I'm not making things worse with the testosterone because I don't want them to have a heart attack or die, which was what the early data shows by being on testosterone repletion.
Right. Okay, I just want to talk a little bit about omega-3. There was a newer study I wanted to just quickly discuss with you that came out, but I'll just explain a little bit of it to the audience. So in 2018, there was the Reduce It study, which kind of started this whole thing. And it was 4 grams of purified EPA against 4 grams of mineral oil placebo. And that study came out as positive. I think there was a 25% risk reduction, and this was a population of people that were already on a statin, low LDL, but high triglycerides. That's correct, right?
Yes, perfect.
So the strength trial came out about 2020, and that was a 4 gram mixture of EPA and DHA against 4 grams of a corn oil placebo. And there's a reason why I'm pointing out the placebos because of some controversy that's come up. And that trial was stopped early for futility, so it never worked. And the trials before were all kind of smaller and they had low doses. So we had these two contradicting studies. And one of the lead authors of the strength trial has come out very, publicly and said that the mineral oil caused such harm in the Reduce It study that it made the EPA look good, that omega-3s do not work. He's gone so far to tell me that anyone who believes that the Reduce It trial is real is an Amarin flunky. So, what are your thoughts on the mineral oil? I know that it did raise some inflammatory markers, but another thing to point out is that one trial was pure EPA, 4 grams compared to EPA DHA, and the EPA was 2.2 grams in that trial. So the EPA levels weren't going to be as high in that trial. And is there something with the DHA? But then that brings us to the Piscus trial, which just came out, which was a smaller trial against corn oil, and it was highly positive, but in a different group of people.
Yeah. So I think the mineral oil definitely caused a small increase in probably LDL and in inflammation. And the FDA knew about that, and the European EMA knew about that, and they calculated what that potential harm would be. And they came up with 3 to 5%. So in a 25% benefit, it can't be explained by a small increase in CRP. It just the math doesn't work. So it wasn't that this wasn't known when the FDA and separately the EMA both approved this drug for use with the indication that it reduces events. But also there were two trials out of Japan using pure EPA, and both of those trials are positive. The JELIS trial and the Respect EPA study. And both of those had no placebo arm. So no
Right.
mineral oil because in Japan they don't believe in placebo. They don't believe in deceiving their population. So you're either on the active treatment or you're not. But they were prospective randomized trials showing benefit in patients on pure EPA. So we have three positive outcome studies, all concordant, showing that pure EPA works. I did a trial called Evaporate, where we looked at CT angio plaque and it reduced plaque, just like the trials that came out of the Japan that showed that CT angio improves more with EPA than with EPA DHA. So they even did an EPA DHA arm, and they showed that EPA did a better job of lowering plaque. So I think it's purely that DHA raises LDL through the PCSK9 mechanism and causes more ApoB. And you don't get that benefit of having less atherogenic particles. You have less triglycerides, but you have more LDL, and that offsets the benefit. So I think DHA cancels out some of the benefit. And when you have higher levels of EPA, like pure EPA, you have better outcomes. And we've known that. We've had many failed trials. And I would just say to anybody who disparages the Reduce It trial, that to even do the strength trial is 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 Einstein's theory of insanity, right? I mean, Einstein said the definition of insanity is to repeat clinical trials and expect different results. And we had seven EPA DHA trials that were done in the high risk population like strength that showed no benefit. So congratulations, they did the eighth trial that showed no benefit.
Right.
And now they're upset that their trial didn't work when Einstein could have predicted that from his grave long ago and saved AstraZeneca probably $400 million dollars.
Right. Yeah, that's a very good point putting it that way because it's not it's hard to believe DHA is bad and that's not what you're saying.
No, I think
For
it's good for the brain, it's good for the eyes. It raises ApoB a little bit, and that might offset a little bit of the benefit, but also you have less EPA, less room for EPA in the capsule when you fill it up with 50% DHA.
right. Yeah, that makes sense to me and I think most people. Okay, so we can end a little bit on diet. So we have, vegan, that extreme all the way to, chicken nugget, fried food type thing. And then we have the keto diet and we have the Mediterranean style diet. So I don't know what your, recommendations are, but there's a little bit of controversy over a keto CTA study that came out. I've never seen such controversy on social media. Um, what was that study about? What was the conclusion, and why is there, such debate about that?
Yeah, so first I just want to clarify the patients we studied in the keto trial that we did was what's called lean mass hyperresponders, which means that they're thin people in excellent shape that are doing the keto diet and their LDLs tend to go way up. And that's not typical for the keto diet. In a normal patient who has enough fat stores and triglycerides to transport energy, they don't see that LDL rise. We see a reduction in diabetes with keto. We see an improvement of Crohn's disease and some of the other bowel disorders with keto. It's great for type 1 diabetes. I've seen patients reverse their type 1 diabetes. They typically lose weight, which is good for the heart. So we're talking about a very specific group of people whose LDLs go crazy on the keto diet. Among these patients, we said we don't know if this is good or bad. We don't like high LDL, so it seemed like it might not be good. So we decided to do a prospective study. We followed 100 patients who are at least 4 years into this keto diet. They tested their ketosis every day, and over the course of a year, we did a repeat CT angio, and we saw in 50% of them no plaque at baseline and no plaque at follow-up. So they were doing fine. And in the other half, there was some level of progression of disease, mostly based on how much disease they had at baseline. So it was more that the underlying plaque predicted more plaque rather than we couldn't find a direct relationship with the high LDL that these patients had. So still somewhat debated as to what that means. But I now take patients who want to do keto, I get a CT angio, I make sure that they don't have disease. If they have disease, independent of keto, I would say you need to be on a statin because you have heart disease, you have athero, and that's what our guidelines say to do. And I recommend a statin. If they don't have any plaque, I don't recommend a statin because that's what our guidelines say to do. Our guidelines say you can forego statin therapy if their calcium score is zero. We have even better evidence now with a CT angio that shows no soft plaque as well. So I'm very comfortable not treating a high LDL from keto if they have normal coronaries.
Right. And you're not saying like that in general, that like it was a specific group of people
A
in
very
that study.
specific subgroup of people that the LDL was only induced because of the keto diet. And it's not because of the food, it's because of their body's response to the to being in ketosis. Their LDLs went up, and it doesn't happen in most people. So it's not like all keto patients' LDLs go crazy. And it's
Right.
not because they're eating a lot of red meat. It's because they typically lose weight, which would lower their LDL. So this is a unique group of patients.
Yeah, and I think that's important because a lot of people came out when that study was published and said that, LDL it was a myth and LDL doesn't cause heart disease and all that stuff. Like that was popping up
No,
all over.
that was a little crazy, I think. I think they overstated their findings to say that LDL isn't causative of heart disease, which I don't believe. I think LDL is quite causative in the typical patient. But this LDL is a little bit different because it's induced only because of this keto diet, and it may be a way of transferring energy which is less efficient than triglycerides because these patients have to be in the study out of low triglycerides and high HDL. So they were metabolically healthy people who were then had no way of transporting energy because they had no triglycerides. Their triglycerides are like 30.
Right.
So the theory is that they're using the LDL, the body's using LDL to transport triglycerides or energy, and it's not very efficient. So your LDL has to go way up.
Okay. So yeah, I just wanted to clarify that it's not that high LDL isn't bad or anything like that. It was a specific group of people in that study.
Very specific to that group. And again, I've never said or wanted to imply that in a high risk individual, LDL is not bad. LDL in a typical patient who's not metabolically healthy, LDL is causative of atherosclerosis and heart disease. And we have data from homozygous FH patients and heterozygous FH patients that they get premature heart disease because they have lifelong high LDL, and they're usually not metabolically healthy patients as a group.
Right. Okay. I think that's going to be the end of our session today, Matt. Thank you for coming on, and I'll hope to have you on again soon. Okay.
I'd love to. I'd love to. Thank you, Aaron. It's been a pleasure.
Yes. Thanks for joining me.
Take
Bye
care.
now.